The great fear, from my point of view, is that at some point, and none of us knows where that is, we reach a point where people say we just can't pay that much, we just can't afford to have everybody have access to the kind of care that, first of all, some people have access to, but that people with good healthcare coverage and good physician relationships and hospitals in their reasonable vicinity have had over the last several decades. So, to me, the fear is that we destroy ourselves by our success. Now, Stuart would point out that there was a time when we said, if we don't keep these costs below 10%, we will bankrupt the whole system. And now we're saying if we don't keep these costs below 20%, but somewhere in there, and none of us knows where it is, there is a point of revolt, and that's what we all have to work together to keep from getting to, while still making practicing medicine worthwhile and rewarding financially as well as professionally and psychically. Now, if I were speaking to the Mass Hospital Association, as I will be with their board in a couple of weeks, they would say, but if you keep making so much noise about provider consolidation, how can we cooperate with you? And I have to say that from the point of view of a payer, we think it is very important to examine provider consolidation as it continues to roll along and see whether it is serving better care, more efficiency, and this goal of collaboration and coordination of care, or is it simply a vehicle to increase revenues by market power? Some consolidations definitely do serve those positive goals. Some, there's little evidence that they do. And it is really important, I think, that we keep that as a topic of conversation while trying to make it civil.
I wanted to tell you, I thought it might be instructive to go over a little bit of our story because we're right in the midst of what's happening in Massachusetts. So, as you heard, I was heading up not only the faculty group, but the contracting organization that contracted for about 1,800 physicians. And in 2009 and 10, when Blue Cross was pushing the first total medical expense budgets, the AQC, we were in negotiations. At the last moment, the medical center pulled out of the concept of taking risk. They said, we're going to stay with fee-for-service. What are you going to do on the physician side? And I said, and I remember this day, the docs will take all the risk. That means 100% of the financial risk went to a physician organization with very little reserves. And some people said, well, why did you do that? And it came down to one slide, and I think it's instructive, a slide of data. And the data were that we'd had 3 years of our claims from Blue Cross, our patients, and that was very useful information. We gave it to an actuary and said, compared to our colleagues in Massachusetts, what is our utilization rate for important things like admissions, emergency room visits, high-end imaging, and things of those natures? And they came back and said, you guys are about average. But you don't use the ED more than most, you don't admit more than most, you're pretty good. And I was smiling to myself and said, we're pretty good. But then I said, go back and compare those same data actuarially. If we gave our 30,000 age, gender adjusted and gave it to Geisinger Health System or to Kaiser and show us our utilization rate, they came back and said your ED utilization is 150% higher than predicted. In other words, there are places in this country that are producing outstanding results, and they use that much less ED visits. 180% high on high-end imaging, 180% high on outpatient laboratory testing, and admissions were high. We were very good on use of generic drugs, because Massachusetts is very good on the use of generic drugs. That was the only thing that we led the nation in. And on those data, I said, Blue Cross knows this? Said, yep. And all that excess care is in my budget? Yep. I said, I'll take the budget. And they said, you don't know how to manage care. I said, I'll figure it out. Because if I don't, and Blue Cross knows that, they have no choice but to hammer me on prices, because the price times volume. So that's how we got into that position. The next thing is that we said, how are we going to get costs down? And the incentive was to incentivize primary care physicians. Now, I'm the CEO of a big academic group, cardiac surgeons, neurosurgeons, big-time researchers, and so forth, and we came up with an internal financing system that says all of the surplus that we generate on the HMO contracts, after we take a little bit for reserves, are going to go to primary care and primary care only. And I got that passed. I think some of my specialist colleagues don't remember that they voted for that, but we have it in the minutes. So we did not think that if you look at who's benefiting from the excess, it's hospital platforms and specialists. And it's unlikely that those people who in the old system are reaping the biggest rewards are going to take a leadership position in lowering the cost, because they have to take it out of their own pockets. PCPs account for 2 to 5% of the budget. The PCPs are underpaid and underappreciated, and I said, the savings you get from all the rest of that medical expense pie is going to be distributed to PCPs. You need to find the best quality care for your patients at the lowest price. That was a pretty easy message for them. The other thing that we did, and this is important when we're talking about insurance, 5% of the population accounts for 50% of the total expenditures. We all know that. That's roughly the number. The flip side of that is 50% of us, the lower 50% of us, the ones who consume the least health care, only consume 2.8% of the total budget, which is good. I haven't heard anyone complain that they are upset about being in that lower part of the population. They're not sick. So we focused on the sickest patients, and the sickest patients don't get less care. They have to be overwhelmed with more care, more personal care in the home, at their place of work, wherever it should be.
So we were $177 million down on $1 billion. And frankly, I stopped counting. I kind of lost interest at that point. And, you know, so you can sell a building. We couldn't, because ours are on city land. You reopen your commercial contracts. Well, we could, but even if Jim gave us everything we asked for, it wouldn't matter, because we didn't have that many of his patients. So we really just had to sort of buckle down and realize and kind of shift our mental thinking to, instead of, you know, our tagline is exceptional care without exception. But instead of saying, okay, we're gonna do everything we can for our patients, we needed to figure out how to do everything that our patients needed at a cost we could afford. We took about $100 million out of our operating base, and the state did about $100 million. So we did half, the state did half, and I think we really kind of renewed our partnership, or renewed our vows, because, you know, 1 in 6 people in the Commonwealth of Massachusetts is on Mass Health. You stand in line at the grocery store behind people who are subsidized. And until we understand that this is the largest and growing part of our business, that if we can't manage the cost of care of these patients, you know, it's going to crowd out everything else we want to do as a society: education, transportation. So for those of you who know me from other organizations will be surprised, I've kind of become a cost hawk. I can see some smiles. I love this. I'm going to get it printed on T-shirts. It really does sort of show the journey that BMC's been on. In 2008, we had a very good year. I think that's part of what started and helped deteriorate our relationship with the state. But in the last 7 years, we've been unable to put forward a positive budget. For the first time this year, we did. In 2012, we had a very modest surplus of $871,000 on $1 billion. And in 2013, we think we'll probably have about a $3 or $4 million surplus. And we put forward to our board for the first time in 7 years a balanced budget going into fiscal year 14. This is a tremendous accomplishment, but it really is. And people say, how did you do this? And I'm not saying this because I'm speaking to a group of physicians, but we did this because everybody on the campus, but specifically the physicians, kind of took a very hard look at what they were doing, how they were doing it, and said, okay, we can do this better. Because if you really care about access to healthcare, and I think everyone at Boston Medical Center does, and everyone in this room does, you have to get costs under control, because otherwise access is going to be slaughtered on the altar of costs. And everyone in this room will get the preventive care that they need, but the patients we serve won't.